called the disease activity score. There are other disease indices. If the trials, proper scientific trials, would use more disease activity indicators, but we use this, and I'm just putting up the slide so that you can understand the figures that we're going to show. These are scores, and if you have a score of more than 5.1 on this DAS 28 thing, that reflects high disease activity. A DAS score of less than 3.2 means low disease activity, and if you have a score of less than 2.6, it means you are in remission. So what happened to our patients when we used them, these 36 patients with rheumatoid? Well, when we started off, the mean DAS score was 6.28, so that was pretty high disease activity. At 3 months, we have figures for 19 patients. The DAS had come down to 3.82, significant improvement. At 6 months, it was down to 3.6, and at 12 months, we have the data for 15 patients. Not all patients have been followed up for a whole year. Therefore, partly the reason why we only have data for 15 patients at 12 months, and the DAS at that time stand at 3.53. Now, these are average figures, but let's have a look at the breakdown. 5 patients actually went into remission as well, out of those that we have data upon. They had DAS scores, or they have DAS scores of less than 2.6. 3 people are in a low disease activity state, which is pretty good by all existing standards in the world. And 25 patients still have moderately active disease, not very active disease. But there were failures as well. 3 patients actually failed to respond. Now, if you take those 3 patients out of a total of 69, then that amounts like a 4.3% failure rate. But if you take these 3 out of the total database we have for analysis, that amounts like 8% of patients who actually failed to respond at all to rituximab. And these are all 3 females with long-standing disease. You can see their ages and the duration of their disease. These 3 totally failed. We have followed these patients up for complications, and we saw actually only 4 complications. 1 patient with aggravation of joint pains, 1 developed quite severe edema of the feet, and 1 76-year-old patient who already had ischemic heart disease. There was possibly a possible contraindication to the use of rituximab, developed SVT and had to delay the second course of infusion, and 1 patient had rather prolonged fever. So 4 complications that we saw. So that covers our experience with rheumatoid. We have also used this in juvenile idiopathic arthritis in 5 patients. Not a recognized indication, but we use them because in our clinical setting, these young people were in lots of trouble. There were several factors. Young girls hoping to get married, mothers couldn't bear to see their young daughters in pain, and they've mostly been all 5 of these have been girls. Age ranges 18 to 28. The disease obviously it started much earlier, and they all improved. You can see the figures. DAS at baseline 6.35, high disease activity score, 3 months 4.18, and 6 months 2.75, and then 12 months beginning to pick up again. The disease beginning to come back at 12 months. Failures or complications in GI, none. Nobody failed treatment, and no complications. We use this in SLE as well. The general accepted indication is lupus nephritis. I even stopped giving her further appointments now, 1 year on. Now, no further appointments unless something happens. She seems to be cured. No, keeping our fingers crossed. Psoriatic arthritis, 1 patient in Karachi. 16 years disease duration, improved. Not an accepted indication for rituximab. Use it with improvement. So let's see how it goes. That was rituximab. Now we come to etanercept, the most expensive of all of all biologic drugs. Limited experience therefore. 10 patients, female to male ratio 9:1, mean age 36 years. Over the years, the average disease activity score before this treatment was 5.7 nearly, and 6 months following the injection therapy, considerable improvement. 2 patients went into remission. Out of these 10 patients, 2 were those who had failed rituximab. Rituximab has had no effect on them. They agreed to use etanercept, and they've not looked back. None of these patients wants to come off etanercept. Etanercept is a magic drug for them. They crib about the cost, you offer them something else, and they retract themselves. We do not want to leave this drug, doctor. Etanercept is doing very well. The cost is a limiting factor. Only 1 patient developed anemia and no parents of TB in any of these 10 patients. One of these patients, it was said to have had TB as a child. I screened her before giving this drug. She did not have any evidence of active TB. She's in her mid-50s. But no TB. It's been like 2 years she's been on etanercept. So, etanercept, good experience. We're following them up, 10 patients so far. Somebody asked about infliximab. Yes, we have used it. Unfortunately, we did not keep any data. These patients came and went. Some of them are actually living abroad. There was one American who came under my care for some time, has returned. One Pakistani boy under my care initially, couldn't afford infliximab while he was here, started on infliximab when he went to Paris because it was free, came back, wanted to see if I could continue it here, lived here for some time, got his drugs from there, but then returned. One big industrialist son shared between myself and Dr. Megatmir, but they didn't stay in this country. Expensive drug, people with that kind of money may not generally stay here. So we really do not have any good follow-up data. But the impression is that it worked well. Infliximab worked well. Tocilizumab, at the moment, not freely available, but manufacturer-sponsored treatment is going on at 3 centers, and we have only selected patients with resistant rheumatoid arthritis. We do not have consolidated follow-up data, but the initial impressions generally amongst our individual discussions are very favorable. Tocilizumab has again done wonders for people who had very resistant disease but not responding to any treatment. Ladies and gentlemen, that's the overall experience so far. Next time we hope to have better quality data, but I thought it was important to present what we have done so far because this is where medicine is going. If there's still time for any questions, I'll be very happy to answer them. Thank you very much.